these like three. Good morning again. This is Ayman El-Hattab. We met before. So we decided to make like these three presentations in both languages, in Arabic and English. So because some people don't feel comfortable in English, so they need like talk with them in their language. So it's like really simple presentation, like telling people about the importance of genetic evaluation and why we do this evaluation. So it will take around 15 minutes, and then after that I'll go across the hall to give it in Arabic to the other group. I don't think we need a clicker. So it is like a brief introduction, and here we focus about genetic evaluation for children with developmental delay and intellectual disability. So first, a brief introduction, and then why do we do genetic evaluation, and then what to do. Very good. Okay, so the definition of a global developmental delay, if we have delay in two or more of the developmental domains, like the gross motor, fine motor, cognition, social and personal activities, and typically developmental delay is given for children less than 5 years. Because the other term, intellectual disability, you need to do an IQ to be able to say that okay, this person has intellectual disability. So for younger children, you label them as the global developmental delay with the prevalence is 1 to 3%. Now when kids get older and you can perform IQ and then you find the IQ less than 70, then yes, and this is the time you say, okay, this is intellectual disability, and again the prevalence is the same, almost the same. So now we have like recommendations from the American College of Medical Genetics and American Academy of Pediatrics that yes, all children with developmental delay or intellectual disability, they should have a comprehensive genetic evaluation. But why to make the evaluation? As because we know that most of we don't have like gene therapy for most of the diseases. So this is like the common question people ask us, like if you find the diagnosis, then are you going to change our genes? And we tell them no, we cannot, unfortunately at this stage, only very few conditions we can. Then why do you do the test? So we always, I mean, this is what I usually do in my clinic, telling them, okay, we need to know why, just to clarify the etiology. And if we know why, then we will have more information about the condition, about the complication that may happen, and what surveillance we need to do, about if we have like kind of like a plan, the treatment, and predict prognosis. Also, it's sometimes you can, like sometimes this will help physicians in choosing the appropriate therapy for that condition. Avoid therapies that you know that they will not be useful. And very important, like we have some specialized clinics. So if we have a specific diagnosis, then you can have like these multidisciplinary clinics managing certain conditions. If you find the diagnosis, you don't need to do additional tests. So if you find the diagnosis, but if you don't find the diagnosis, you keep doing tests one after another. Family support, very important. Most of family support groups are like specific for specific diseases. Very important research. If I have the specific diagnosis, I can join clinical research. Sometimes to get some services, you have a specific diagnosis. And of course, very, very, very importantly here, especially for this region, because we have high prevalence of recessive diseases, is prevention. Prevention, if we find the mutation, this will help us in prevention. So what do we do? So first of all, what are the elements of genetic evaluation? Like any other clinical practice, we start from reviewing the history and performing the examination and review previous results, and then we have like an initial assessment for the patient's situation, and then we can discuss now what are testing options that we have, and what are the expected results. And then we do, it's very important to do pre-counseling, pre-test counseling. So we need to counsel patients about what test we are doing and what we are expecting. It makes it very easy if you tell me before about, like, for example, variant of uncertain significance, that okay, sometimes we get changes that we don't know if they are normal or abnormal. It will be easier if you start like before the test, because people expect, okay, the test will be positive or negative, like any other test. And then after the test, we have the post-counseling session. We need to counsel them about the results, and then we can base the management change, like make management plan and surveillance according to the diagnosis that we have. But the question is how to choose. We have many options. So it's like the first question, I mean, are we suspecting something specific or not? If we're suspecting like Fragile X syndrome, so yeah, at that time we go ahead and do specific tests for Fragile X, like the trinucleotide repeat for FMR1. If we are suspecting really very, again, like if not suspecting, if you want just maybe to confirm that this baby has Down syndrome or no, the type of chromosomal abnormality in this baby, you do karyotype. I mean, the utility of karyotype now is very limited, maybe just mainly for Down syndrome. If you're suspecting Williams syndrome, for example, then maybe you can do chromosome microarray. Very rarely, like you have like someone with classic features of Marfan, and maybe you can do one gene, single gene. So, but this, to be honest, this is like the very small percentage of patients we see. Most of patients we see, they come with developmental delay, non-specific dysmorphic features. They don't suspect something specific. And in these cases, now we go to the exome and genome. This is, I think, that this is the latest recommendation from the American College of Medical Genetics. It's now 1.5 years old, where they looked at the utility of whole exome and genome in developmental delay and intellectual disability. And clearly they said, please start with this test. Strongly recommend to do exome and genome as the first tier, because the diagnostic yield is much higher than any other test by itself. And of course, the genome has higher yield than the exome. And this paper was also nice. They looked at the effect of the results, like will this affect the short-term active clinical management? And the answer was yes, in around like 10% affecting the short-term, another maybe 10% affecting the long-term management, and another 10% maybe affecting reproductive decisions about, like, I mean, of course, in our region, this number is maybe like 50%, because we diagnose many people with recessive diseases, and most of them will go and do IVF for that. And family-focused outcome. And again, here you have many, like if you diagnose someone in the family, then all family members can come and test. Now the question about the cost. I mean, it's logic. Like if you do all different tests, and then after doing all these tests, you do the exome, it will be additional cost. But if you start with the exome, no, actually you are saving money, because the exome, it will be, you will reach the diagnosis at lower cost than doing multiple tests. And this was like clearly, they looked clearly at this point, and they said, yes, if you start with this test, this will reduce the cost. Of course, limitations. I mean, the first limitation is not true. I mean, it's the earlier versions of the exomes, they did not look at the deletions, but now I think most of the exomes, they will do the copy number variation analysis. So if you have a chromosomal deletion, it will be picked up. Again, trinucleotide repeat still, if you suspect Fragile X, for example, you need to do specific test. Methylation, like Bicuit-Widman, again, you need specific test for that. And if you're using the exome, then of course you will miss the intronic mutations. Now the genome theoretically will cover everything. So now after the exome, of course you can consider the genome, but there are other things that can be done, like the global metabolomic profiling, for example, and methylations, and many other tests. I think will be now people start looking at the transcriptome and other things. So I will stop here, and maybe we have a few minutes if anyone has any questions. Yes, please.
Thank you, Dr. Ayman, for a nice presentation. I have a question. I work in a center of people of determination. So we have a wide variety of, global development delay, or even, genetic disorder. They come with a phenotype, a specific phenotype. But we, I as a doctor, I have no idea in which classification they are, as a constellation of this phenotype. Is there any site or in facility so we can look for? And so this might be categorized under this syndrome.
I will let Dr. Segal answer this question.
Sorry.
Yes, the simul-consult.
About that?
Simul-consult. Dr. El-Hattab
Yeah.
Is our lead contributor
For genetics.
for genetics.
Yeah.
And we have contributions across all of pediatrics. And so, you can go, you can put the phenotypic information in and get a differential diagnosis and recommendations on the most useful tests. And all of the information, and Dr. El-Hattab can tell you more about this also, and Dr. Siegel, is all curated by specialists in the field. So you're not getting random information here of questionable quality, and it's all from the reference literature. And what the software does is compare your patient, the findings that you put in, to our database that is curated from the literature to provide you this information.
And when you get the results from an exome or a genome, there'll be lots of abnormalities, some that are random and some that are true. And when one gets the information from a genome or an exome, one can look at that information in the clinical context, so to see which part is real and which isn't, and see what is the most pertinent gene, which in studies that we did together with Dr. El-Hattab showed that metric of pertinence was highly predictive of what the correct diagnosis is.
Here's some information
which
about
brings me
the-
to a question.
Oh, that's nice.
To what degree do you always try to do a trio including the parents?
No. Yeah, most of the time we do solo.
And so to what degree, how many apparent, so you don't know how many variants are de novo, and so do you have, because we found with the output of many companies that they have huge numbers of de novo even when they do a trio, they have huge numbers of de novo variants, and you're chasing down ones that you don't know if they're real.
Yeah,
So
yes.
that seems to be a big issue, and I wonder how you deal with it.
Because many times we go recessive conditions, so this will be the end of the story. But when we have the, we do target testing for parents. This is what typically we do, because the largest percentage will be recessive. So when you have homozygous mutation, you kind of know, like cousins homozygous, really, we don't test parents. But for heterozygous mutation, we do target, so this will make the cost a little lower. So I will, just to stick with the time, I will go to the other hall, and Shaima, Dr. Khawla will come and give her presentation, and I'll be around. Thank you.